Good morning, everyone. I'm Dr. Asim Hassin, and I'm pleased to welcome you today. Today's presentation is on environmental emergencies. We'll explore the key issues surrounding environmental emergencies, their impact, and how to respond effectively. So, let's get started and dive into this important topic together. Let's take a closer look at this case. We have a 62-year-old man who collapses during a heat wave, which immediately raises concerns about heat-related illnesses. His core temperature is alarmingly high at 41.2 degrees C, indicating a severe hyperthermic state. He's also confused and hypotensive, suggesting he's in shock or experiencing organ dysfunction. Additionally, his elevated CK and transaminases point toward muscle damage and liver involvement, which are common in heat-related conditions. Now, considering these clinical features, the most likely diagnosis here is heat stroke. It's a true medical emergency characterized by a core temperature above 40 degrees C and central nervous system dysfunction. Recognizing this helps us understand the importance of rapid cooling and supportive care in such scenarios. This case ties into the broader theme of how extreme environmental conditions can precipitate life-threatening illnesses, emphasizing the need for quick identification and intervention. Let's take a closer look at what defines heat stroke. The correct answer here is D. So, heat stroke occurs when the core body temperature reaches 40 degrees Celsius or higher. But what's really critical is that it's not just about the temperature. We also see central nervous system dysfunction, which can manifest as confusion, seizures, or even coma. Additionally, organ injury is a key component, indicating that multiple systems in the body are affected. Interestingly, despite the severity, sweating might still be present in some cases, so you can't rely solely on the absence of sweating to diagnose it. Recognizing these combined features is essential for timely diagnosis and intervention. This ties back into our overall theme of understanding heat-related illnesses and emphasizing the importance of early recognition and treatment. Now, let's focus on the scenario presented here. The patient has been transferred to the ICU with persistent hyperthermia and altered mental status. This situation is quite serious and requires us to act quickly. The key question is, what is the most important immediate intervention in this case? Looking at the options, we have several choices, but the most critical step is to identify what will most effectively stabilize the patient. In cases like this, rapid active cooling is essential to reduce the dangerously high body temperature. Elevated temperatures can cause significant brain injury and other organ damage if not addressed promptly. While medications like IV paracetamol or antibiotics have their roles, they are not the immediate answer in this acute crisis. Dantrolene is used in malignant hyperthermia, but unless there's strong suspicion of that specific condition, it's not the first-line treatment here. Immediate intubation alone may help with airway management, but doesn't directly address the hyperthermia. So, highlighting the most important point, rapid active cooling is our priority to prevent further complications and stabilize the patient quickly. This step aligns with our overall goal of managing hyperthermia aggressively and efficiently in critical care settings. The correct answer here is C. Now, let's delve into why that is. Rapid active cooling is absolutely life-saving in this situation. It's crucial to understand that antipyretics, which you might normally think of using to reduce fever, simply do not work here. That's because this isn't a problem with the hypothalamic set point. Instead, the issue is with the body's temperature regulation due to other factors, so we need to act quickly with active cooling methods. This slide emphasizes the importance of recognizing the type of fever or hyperthermia we're dealing with, so we can choose the most effective intervention. Remember, timely and appropriate cooling can make all the difference in patient outcomes. Now, let's look at this question. A homeless man presents with a core temperature of 30 degrees Celsius, which indicates severe hypothermia. The ECG shows a prominent positive deflection at the J point, which is a key feature here. This finding is called a Osborn wave, also known as a J wave. It's important because it often appears in cases of hypothermia, especially when the core temperature drops significantly. Recognizing this wave can help us quickly identify hypothermia on an ECG, which is crucial in emergency settings. So, the correct answer here is C, Osborne J wave. Understanding these specific ECG patterns helps us connect clinical signs with underlying conditions, reinforcing our overall theme of accurate diagnosis through ECG interpretation. The correct answer here is C now. Let's discuss why that's the case. Osborne waves, which are also known as J waves, are quite characteristic and are typically seen in cases of moderate to severe hypothermia. When you see these waves on an ECG, it's a strong indicator that the patient's body temperature is significantly lowered. Recognizing these waves is important because they help us identify hypothermia early, which is crucial for proper management. Remember, the presence of Osborne waves points toward a more severe hypothermic state, guiding us to prioritize rewarming and supportive care. So, in the context of our overall discussion on ECG changes, spotting Osborne waves can be a key diagnostic clue in hypothermic patients. All right, let's focus on this critical decision point. When a patient develops ventricular fibrillation at a core temperature of 28 degrees C, the question is, what is the most appropriate management strategy? Looking at the options, we need to consider the principles of treating hypothermic cardiac arrest. At this temperature, the heart is very sensitive, and the usual resuscitation protocols may need adjustment. Option A suggests terminating resuscitation. While this might be considered in some cases, if there's any chance of rewarming and recovery, we shouldn't give up just yet. Option B involves repeated defibrillation attempts. Interestingly, in hypothermia, the heart's electrical activity can be very resistant, and multiple shocks may be more harmful than helpful. Option C recommends withholding CPR, but that's generally not appropriate unless there's a clear contraindication. Option D, continuing CPR until the patient is rewarmed, aligns with the understanding that hypothermia can protect the brain and heart, and ongoing resuscitation efforts, combined with rewarming, can lead to a good outcome. Finally, option E, immediate thrombolysis, isn't relevant here because the primary issue is hypothermia, not a thrombotic event. So the key takeaway is that in cases like this, the best approach is to continue CPR until the patient is rewarmed enough to potentially restore normal heart rhythm. This underscores the importance of patience and proper rewarming techniques in hypothermic cardiac arrest. The correct answer here is D, and I want to emphasize an important point. The saying, "not dead until warm and dead," really captures the essence of managing hypothermic patients. It means that even if someone appears unresponsive or pulseless, as long as they are cold, you should continue resuscitation efforts. Warming the patient is crucial, and ongoing CPR can be life-saving. Also, keep in mind that drugs and electrical shocks tend to be less effective when the body temperature drops below 30 degrees Celsius. So, our focus should be on rewarming and continuing resuscitation efforts rather than giving up prematurely. This concept aligns with the overall theme of managing hypothermia carefully and persistently, because the patient's prognosis can still be hopeful with proper treatment. Let's analyze this case. We have a young man rescued from a lake, presenting with hypoxia, pink frothy sputum, and bilateral crackles. These signs are classic for pulmonary edema, which often occurs in drowning victims. Now, looking at the options, the key question is, what is the primary cause of death in drowning? Among these choices, aspiration pneumonia is a common complication, but not typically the immediate cause of death. Hypothermia is relevant, especially since he's in a cold environment, but again, it's not the primary cause here. ARDS, or acute respiratory distress syndrome, is highly pertinent because the injury to the lungs from aspirated water and the subsequent inflammatory response can lead to severe hypoxemia. Hypoxia, of course, is the immediate problem, the lack of oxygen, but it's a consequence rather than the primary cause of death. Electrolyte disturbances can occur, especially with prolonged submersion, but they are usually secondary. So the most critical point here is that drowning primarily causes hypoxia through pulmonary mechanisms, leading to respiratory failure. Therefore, the best answer that highlights the primary cause of death in drowning is ARDS, which represents the severe lung injury and hypoxemia resulting from the drowning process. In summary, understanding that ARDS is the main pathway leading to death helps us appreciate the importance of prompt respiratory support and management in these cases. The correct answer here is D now. Let's break down why. The primary mechanism at play in this situation is hypoxia, which is a deficiency in oxygen reaching the tissues. This is actually the main cause behind the problem we're discussing. ARDS, or acute respiratory distress syndrome, is actually a consequence that results from hypoxia. So, in essence, hypoxia triggers the cascade that leads to ARDS developing. Understanding this order, hypoxia as the principal mechanism and ARDS as a consequence, is crucial because it guides how we approach diagnosis and treatment. Recognizing that hypoxia is the root cause helps us target our interventions more effectively. This connection also ties into the broader theme of respiratory failure management, emphasizing the importance of early detection of hypoxia to prevent progression to more severe conditions like ARDS. Let's look at this case carefully. We have a man presenting with headache, dizziness, and nausea, which are common symptoms that can be caused by various conditions affecting oxygen delivery or utilization. The arterial blood gas shows a normal PaO2, and pulse oximetry reads 100%, indicating that the oxygen saturation appears normal. This is a key point because it suggests that the problem isn't with the amount of oxygen in the blood, but rather with how the oxygen is being used or transported at the tissue level. Now, considering the options, the most likely cause here is methemoglobinemia. In methemoglobinemia, hemoglobin is altered so it can't effectively release oxygen to tissues, even though blood oxygen levels seem normal on tests. This results in symptoms like headache, dizziness, and nausea despite normal oxygen readings. Understanding this helps us see that sometimes the clinical picture doesn't match the standard test results, and we need to look deeper into the physiology. So, the best answer here is C, methemoglobinemia, because it explains the symptoms combined with normal PaO2 and pulse oximetry. The correct answer here is B now. It's important to understand why. Pulse oximetry, which many of us rely on for quick oxygen saturation readings, can actually be misleading in cases of carbon monoxide poisoning. That's because pulse oximeters can't distinguish between oxyhemoglobin and carboxyhemoglobin. So, even if someone is severely poisoned, their pulse oximetry reading might appear normal or only slightly decreased. This is a critical point because it can lead to a false sense of security. The real key to diagnosing co-poisoning is measuring the actual levels of carboxyhemoglobin, which requires specific blood tests. Relying solely on pulse oximetry could delay the correct diagnosis and treatment, so awareness of this limitation is essential in clinical practice. Remember, in suspected cases of co-poisoning, confirming with COB levels is the most accurate approach. Now let's look at this clinical scenario. We have a pregnant woman with a COB level of 22% and mild confusion. The question is, what is the most appropriate treatment? First, it's important to recognize that carbon monoxide poisoning is a serious condition that requires prompt management. The options listed include room air observation, normobaric oxygen, hyperbaric oxygen, intubation, and exchange transfusion. Given her COB level of 22%, which indicates significant exposure, and her neurological symptoms like confusion, we need to act swiftly. Room air observation alone is insufficient here because it won't effectively displace CO from hemoglobin quickly enough. Administering normobaric oxygen, that is, 100% oxygen at normal atmospheric pressure, is typically the first-line treatment to accelerate the elimination of CO. Hyperbaric oxygen, on the other hand, involves delivering oxygen at higher pressures in a specialized chamber, which can be more effective, especially in cases with neurological symptoms or higher COBE levels. Intubation might be necessary if her airway is compromised or if she can't maintain her airway, but in this scenario, it's not the primary treatment. Exchange transfusion is rarely used nowadays and is reserved for very severe cases or when other treatments aren't effective. So, considering her level of COBE and her symptoms, the most appropriate initial treatment would be administering high-flow oxygen, specifically normobaric oxygen, while closely monitoring her condition. This approach helps reduce the COBE level efficiently and minimizes her neurological risks. Remember, timely intervention is key to preventing long-term neurological damage, especially in pregnant patients where both maternal and fetal health are at stake. The correct answer here is C now. Let's discuss why that's the case. Pregnancy is actually a strong indication for hyperbaric oxygen therapy. The main reason for this is the risk of fetal hypoxia, which means the fetus isn't getting enough oxygen. In situations where oxygen delivery is compromised, hyperbaric oxygen can really make a difference by increasing the amount of oxygen available to both the mother and the fetus. So, when we encounter pregnant patients with certain conditions, this therapy becomes a crucial option to protect fetal health. This ties into our overall theme of understanding when hyperbaric oxygen is indicated, especially in high-risk situations like pregnancy. All right, let's look at this question about a man who sustains a high-voltage electrical injury at work. When considering the most dangerous immediate complication, it's crucial to understand the potential effects of electrical burns. While skin burns are common and visible, they are often not the most immediately life-threatening issue. Arrhythmias, however, are a significant concern because electrical currents can interfere directly with the heart's electrical system, potentially causing dangerous heart rhythms right away. Infection and compartment syndrome are serious, but they tend to develop over a slightly longer period. Renal failure can occur due to muscle breakdown releasing myoglobin, but again, this is usually a secondary concern rather than an immediate threat. So, in the context of high-voltage electrical injuries, arrhythmias are the most critical and immediate danger to address. The correct answer here is B now. Let's talk about why that's the case. Malignant arrhythmias, specifically ventricular fibrillation and asystole, are actually the leading immediate causes of death in many cardiac emergencies. These are the types of arrhythmias that can cause sudden cardiac arrest if not addressed promptly. Recognizing these is crucial because they require immediate intervention, such as defibrillation or advanced cardiac life support. This point ties back to the overall theme of the presentation, which emphasizes the importance of rapid response and accurate identification of life-threatening arrhythmias to improve patient outcomes. Now let's look at this scenario. A snakebite victim presenting with bleeding gums, an INR of 5.2, and low fibrinogen levels. These signs indicate a significant coagulopathy, which is common in venomous snake bites that affect blood clotting. The key here is to identify the most effective definitive treatment to reverse these effects. Looking at the options, platelet transfusion, FFP alone, antivenom, tranexamic acid, and steroids, we need to consider which one directly addresses the underlying cause. In cases like this, the primary and most effective treatment is antivenom. It works by neutralizing the venom components that interfere with the clotting process, helping to restore normal coagulation. Other options like tranexamic acid or steroids might help in some bleeding scenarios, but they don't tackle the root cause here. Platelet transfusion or FFP can provide temporary support, but without antivenom, the venom will continue to cause issues. So, to sum up, the definitive treatment for this snakebite-induced coagulopathy is antivenom. It's essential to administer it promptly to prevent further bleeding complications and facilitate recovery. The correct answer here is C, and the key point to remember is that only antivenom can reverse venom-induced consumption coagulopathy. This condition occurs when the venom triggers widespread activation of the clotting system, leading to consumption of clotting factors and platelets, which results in bleeding tendencies. It's crucial to understand that supportive measures alone won't reverse this process. Antivenom contains antibodies that directly neutralize the venom, effectively stopping this coagulopathic process. Recognizing this distinction is vital for effective treatment, as timely administration of antivenom can significantly improve patient outcomes. This ties back to the overall theme of understanding the specific mechanisms of venom effects and the appropriate interventions to counteract them. Let's start by distinguishing between heat exhaustion and heat stroke. Heat exhaustion is primarily characterized by volume depletion, meaning the patient is dehydrated, but importantly, there's no central nervous system dysfunction. This is a key point because it helps us differentiate it from more severe conditions. In contrast, heat stroke is a true medical emergency. It carries a significant mortality risk, ranging from 10 to 50% if not treated promptly. The critical aspect here is that heat stroke involves not just elevated body temperature, but also dysfunction of the central nervous system, which requires immediate intervention. When it comes to cooling methods, evaporative cooling is often the first line. Think of spraying the patient with water while fanning them to promote heat loss. Ice packs applied to specific areas like the neck, groin, and armpits can also be very effective. Cold intravenous fluids are another option, especially in severe cases, to quickly reduce core temperature. It's important to remember, avoid giving antipyretics like acetaminophen or aspirin. These medications are not effective in heat-related illnesses because the problem isn't a fever driven by the hypothalamus, but rather heat overload. Now, let's talk about some serious complications that can arise if heat stroke isn't managed properly. Rhabdomyolysis, which is muscle breakdown, can lead to kidney damage. Disseminated intravascular coagulation, or DIC, involves abnormal clotting and bleeding. Acute kidney injury and even acute liver failure are also potential outcomes. The ultimate goal in treatment is to bring the core body temperature below 38.5 degrees Celsius as quickly as possible. Rapid cooling is essential to prevent these life-threatening complications and improve the patient's chances of recovery. In summary, recognizing the signs early and acting swiftly with effective cooling techniques can make all the difference in managing heat illness and preventing severe outcomes. Let's talk about hypothermia classification. Mild hypothermia occurs when the core temperature drops to between 32 and 35 degrees Celsius. At this stage, patients often shiver as the body's natural response to generate heat. Moving into moderate hypothermia, with temperatures from 28 to 32 degrees Celsius, we start to see more serious issues like arrhythmias, which can be quite dangerous. When temperatures fall below 28 degrees Celsius, we are in severe hypothermia territory, where patients can become comatose or develop ventricular fibrillation, which is life-threatening. It's very important to handle hypothermic patients gently because rough handling can increase the risk of triggering ventricular fibrillation. Now, rewarming is a critical part of management. We have several methods. Passive rewarming, which involves using blankets to help retain body heat, active external rewarming, such as forced air warming blankets, and active internal rewarming, which includes warmed IV fluids or even ECMO in severe cases. During hypothermia, ECG abnormalities are common, so we need to be vigilant. Also, it's generally advisable to withhold adrenaline or defibrillation until the core temperature reaches at least 30 degrees Celsius if possible, because the heart may not respond normally at lower temperatures. Overall, understanding the classification and careful rewarming strategies are key to improving outcomes in hypothermic patients. Let's start by clarifying that whether the water is fresh or salt doesn't really change the clinical approach or outcome, so it's generally considered clinically irrelevant. When someone aspirates water, it can trigger a laryngospasm, which is a sudden, involuntary spasm of the vocal cords. This can lead to aspiration of water into the lungs, causing alveolar injury. In managing these cases, we treat the lung injury similarly to acute respiratory distress syndrome, or ARDS. That means focusing on early oxygenation to ensure the brain and organs get enough oxygen, and using lung protective ventilation strategies to minimize further lung damage. Antibiotics are not routinely used unless there's clear evidence of infection, so only if infection develops or is suspected, not just because of aspiration. The prognosis in drowning cases largely depends on factors like how long the person was submerged, the temperature of the water, since cold water can sometimes have protective effects, and how quickly rescue efforts were initiated. In summary, drowning is a complex event, but understanding these key points helps us manage it more effectively and improve patient outcomes. Let's talk about carbon monoxide and its effect on hemoglobin. CO binds to hemoglobin with an affinity that is about 200 times greater than oxygen. This means that CO essentially outcompetes oxygen for binding sites, drastically reducing the blood's ability to carry oxygen to tissues. As a result, tissues can become hypoxic, which can lead to serious issues like tissue hypoxia itself, myocardial injury, and even delayed neurologic sequelae that might not show up immediately but can be quite damaging later on. Now, when should we consider hyperbaric oxygen therapy? Generally, if the carboxyhemoglobin level is 25% or higher, or if the patient is pregnant, has cardiac ischemia, or shows neurologic symptoms, immediate treatment with 100% oxygen is indicated. The main goal here is to quickly displace CO from hemoglobin and restore oxygen delivery. Remember, CO poisoning is a medical emergency that requires prompt recognition and treatment to prevent long-term complications. Let's talk about ECG monitoring for at least 24 hours. This is crucial because cardiac issues can develop or become evident over time after an electrical injury. Continuous monitoring helps us catch arrhythmias early and ensures patient safety. Now, regarding skin injuries, it's important to remember that what we see on the surface often underestimates what's happening beneath the skin. Deep tissue damage can be much more severe than a superficial burn might suggest, so we need to be vigilant for signs of underlying injury. When assessing these patients, look out for specific complications. Rhabdomyolysis is a key concern because it can lead to acute kidney injury, or AKI. This occurs when muscle breakdown products clog the kidneys, so early detection and management are vital. Compartment syndrome is another serious issue. When swelling within a muscle compartment increases pressure dangerously, it can compromise blood flow and nerve function. Recognizing this early can prevent permanent damage. Neurologic injury is also common in electrical injuries, given the electrical current's ability to disrupt nerve function. Watch for signs of nerve damage or neurological deficits, as these can influence our treatment approach. For high-voltage injuries, these patients often require ICU admission. The higher the voltage, the greater the risk of severe internal damage and systemic effects. Close monitoring and supportive care in the ICU are often necessary. Finally, remember that electrical injuries can be complex and multifaceted. Staying alert to these complications and understanding their implications helps us provide comprehensive care and improve patient outcomes. When treating snakebite envenomation, the key principle is to focus on the clinical picture rather than just the fang marks. It's important to assess the patient's symptoms and signs to guide management effectively. Antivenom is indicated in cases of neurotoxicity, which can cause paralysis or breathing difficulties, coagulopathy, leading to bleeding issues, or shock, which indicates a severe systemic response. However, it's crucial to avoid certain traditional practices like incision, trying to suck out the venom, or applying tourniquets, as these can do more harm than good and worsen the patient's condition. Supportive care in the ICU is often critical, providing respiratory support, managing hemodynamics, and monitoring closely are essential components of treatment. Remember, the goal is to manage envenomation comprehensively, prioritizing clinical stabilization over superficial wound care. All right, let's go over some critical clinical pearls to keep in mind. When it comes to heat stroke, the priority is to cool the patient first and then ask questions later. Don't delay cooling to investigate further. For hypothermia, rewarming must be done before pronouncing death, since body temperature recovery can be life-saving. In cases of drowning, hypoxia is the main culprit, so focus on restoring oxygenation promptly. With carbon monoxide poisoning, remember that normal SbO2 readings can be misleading because they don't detect carboxyhemoglobin. So rely on other diagnostic methods. For electrical injuries, always get an ECG first to assess for arrhythmias or cardiac damage. And when dealing with snakebite bleeding, antivenom is the key treatment. It's more effective than simply transfusing blood products. These pearls emphasize the importance of understanding the underlying pathophysiology to guide effective management. Always remember, quick and appropriate responses can make a huge difference in patient outcomes. Thank you so much for your time and attention. I really appreciate you being here today. I hope the insights we've shared have been helpful and inspiring. Remember, the key takeaways are the importance of understanding the core concepts, applying them effectively, and always staying curious. This presentation is part of a larger journey toward growth and innovation, so I encourage you to take these ideas forward. Thanks again for your engagement, and I look forward to seeing how you implement these strategies in your own work.